Foley catheter insertion. Part of being a nurse is assisting our clients with urination or elimination. During acute illness, sometimes a client is going to require catheterization to help make sure that they are putting out enough urine, or possibly even to facilitate emptying of the bladder. Some clients will require long-term indwelling catheter, whether it's urethral or suprapubic. We have to use evidence-based practice. There's many associations such as the Centers for Medicare and Medicaid Services and the Centers for Disease Control and Prevention that have published guidelines and recommendations for preventing complications with the use of indwelling urinary catheters in the acute care setting, such as catheter-associated urinary tract infections. All of these evidence-based guidelines or goals describe common practices that nurses should incorporate when performing urinary catheterization and/or caring for clients with indwelling catheters. We also have to always be sensitive to cultural differences and, if at all possible, provide same-gender caregiver care. Indwelling catheters should never be inserted for nurses or clients' convenience because it does cause an increased risk of infection. Urinary catheterization involves the placement of a tube through the urethra into the bladder to drain urine. It is an aseptic technique and it does require a physician's order. Steps for insertion for an indwelling and a single-use straight catheter are the same. The only difference is there an inflatable balloon at the end of an indwelling catheter that helps keep it anchored in the bladder. A single-use catheter is often used when the client has an inability to void. It's used to obtain sterile urine specimens. It's also So if we have a client that has some abdominal discomfort, they are not emptying out their bladder, etc., sometimes the doctor will order us to check residual urine, and we use the single-use or straight catheter within 10 minutes after that client has voided. A volume of less than 50 mL is considered to be normal, but over 100 it requires investigation. And definitely watch out for client allergies to latex because most urinary catheters are latex, but they do make some silicone ones. So again, we have latex or silicone catheters. Silicone do have a larger internal diameter. We have some that are antimicrobial, so in other words, they're medicated. We have the straight or the intermittent. The size is based on a French scale. The larger the number, the larger the catheter. Balloon sizes are on indwelling catheters and they vary. You may have some that are only 5 mL, you have some that are 10, you have some that are 30. So usually if you look at the inflation valve, for example on B, you see that two little pigtails there on the left hand side. That little pink plastic piece has some writing on it, and that writing will tell you what size the catheter is and what size the balloon is. And then the catheters are attached to a drainage bag. Some drainage bags will have a urometer so you can measure the urine more easily, especially if you're doing like hourly outputs. And straight catheters often are attached to just a small drainage bag. Catheter changes are individualized and they're not routine. They should not be changed frequently because it increases the risk for infection. You do change a catheter if there's any leaking or blockage. And we try to avoid long-term catheterization when possible, removing them as soon as we can. Remember to always keep the bag below the level of the bladder, and it shouldn't touch the floor. And make sure any excess tubing is coiled on the bed. This is a JCAHO requirement. So insertion, do your sweep hat. Position your client. Those females need to be in a dorsal recumbent position. The males can just be supine. Make sure that the client does not get cold and you only expose what needs to be exposed. They need to have a pad underneath them to help prevent any soiling. Do pericare prior to insertion. Understand that putting a catheter in cannot be delegated to a nurse aide unless the nurse aide has had specialized training. Make sure you have appropriate lighting. Open up your kit. Everything inside the kit is sterile. So you're going to put your sterile gloves on first and then place the drapes, maintaining sterility, and get your supplies where you want them. Put your antiseptic over the cotton balls. Open up the lubricant, and you're going to lubricate the catheter tip and attach the sterile saline, if it is an indwelling catheter, to that pigtail so it's available for you. Cleanse the meatus. With the women, you're going to use your non-dominant hand, and it will now be dirty, and you keep that hand there until you're finished with the procedure. Separate the labia. Using your dominant hand, take the forceps, grab a cotton ball that's been soaked in antiseptic, and cleanse. You go down one time with each cotton ball. You're going to do each labia, and you're going to do the midline. And it doesn't hurt to use all that you have available there. So go through all of your cotton balls. Don't just do 3. On the males, if the foreskin is present, retract the foreskin. You hold the penis in your non-dominant hand. Cleanse the glands in circular motions going from the meatus all the way outwards. And you do this again several times. The non-dominant hand is going to stay there. It's not going to move until the procedure is over. Coil the catheter in your dominant hand and place the tray as appropriate. I prefer to place the tray between the patient's legs because it helps prevent me from contaminating my catheter. If you ask the woman to bear down, it will help you visualize the meatus. With the guys, you need to hold the penis at a 90-degree angle and sometimes even tip it back towards their head. This does help facilitate passage. You insert the catheter until the flow of urine is obtained, and then go 1 or 2 more inches. Then inflate the balloon if it is an indwelling catheter. Once you start getting your flow of urine and you've gone 1 or 2 inches more, with your non-dominant hand, you can reach up, grab a hold of the catheter to hold it, and then using your dominant hand, you will inject the fluid into the catheter and disconnect, because if you don't disconnect, it's pressurized and the fluid will come right back out. So keep the pressure on the plunger until it's disconnected. Then you gently tug the catheter until you feel it anchored in place, and then you cleanse up the perineum and place your catheter bag. Obtain a specimen if necessary. Perform perineal care. As I said, CACO, the urine return. If the urine return is too fast, it can actually cause urinary or bladder spasms. Clients often will complain of urgency even though they have that catheter in place, and even though you tell them they have a catheter, they still complain that they need to pee. So make sure you determine patency of the catheter. Make sure there's no kinks in the catheter. And sometimes if if they're complaining, if you raise the catheter up above their body several inches and then you lower it again, it's like it primes the pump, so to speak. Maybe the catheter was in an air pocket or something, but this actually gets the catheter to flowing again. So when you're documenting, document all of these items that are listed on your slide and educate your client. Let them know that it is normal for them to feel some urgency at times with the catheter, because that catheter is compressing some of those nerves that make them feel like they have to go. Make sure they're taking in adequate amounts of fluid. Instruct them do not pull on the catheter and to keep the bag below the level of the bladder. It is possible to change the Foley bag without changing the catheter, but it is a sterile technique. It is also common to do bladder training prior to removal, especially if the catheter has been in place for an extended period of time. To do bladder training, you clamp the catheter and then you release or you unclamp it routinely, maybe every 2 to 3 hours, or when the client feels like the bladder is full. It helps improve the bladder tone. Removing the catheter is a clean procedure. Make sure that you drain the collection chamber and completely deflate the balloon with the syringe. You should look at the insertion documentation to see how much fluid was injected, but sometimes if a catheter is leaking, a little bit more fluid will be injected to help seal it off a little better, so to speak. So don't always trust that what is on the little pigtail is exactly the amount of fluid that's in the catheter. What I do is I withdraw as much fluid as I can into my syringe, disconnect my syringe, squirt it into a trash bag, and reconnect it and see if I can draw any more fluid out. Then I'm making sure that I have everything out. You will measure some voids following removal, and it can be up to 24 to 48 hours depending on how the client's doing, how much they're voiding, etc. They need to void at least 150 mLs. That will indicate that they're not having some complications from the catheter. So you will document time of removal, the amount of water removed from the balloon, meatal and perineal condition, the time, amount, and characteristics of the first voided urine. Other types of urinary catheters, you can have an external catheter, which is also known as a condom catheter or a penile sheath. It fits over a penis to contain urine. Make sure that you keep kinks out, and again, keep it below the level of the bladder. Do not secure it too tightly because you do not want to cut off circulation, but it has to be secure enough that it's held in place. And monitor skin condition. And then you also have suprapubic catheters, which are surgically inserted through the abdomen, usually due to a blockage of the urethra or if a long-term catheter is required. And this is what you have a picture of on your slide.